Hello, my name is Manesh Patel. I'm the Chief of Cardiology and Director of the Heart Center here at Duke University. Thanks for joining me as we discuss the medical management of our patients with peripheral artery disease and coronary artery disease, often termed PAD and CAD. It's important first to think about atherosclerotic disease, and we've learned a lot about atherosclerotic disease in our lifetime, but our knowledge has evolved. It's important to recognize that atherosclerosis is a systemic, inflammatory, atherothrombotic disorder. And what do I mean by that? I mean that over our lifetime, a variety of inflammatory and other features cause the vessel wall to get disrupted. Over our lifetime, because of metabolism, genetics, and other things, we put down cholesterol and lipid particles into that vascular wall. And over our lifetime, unfortunately, as that vascular wall and plaque builds, there can be disruptions in healing. And unfortunately, sometimes that inflammation and disruption leads to plaque rupture, the start of thrombosis. And thrombosis either happens at the vessel there or leads to downstream thrombotic occlusion. So atherosclerosis in its most basic pathophysiologic form is an inflammatory atherothrombotic disorder where the downstream consequences are what leads our patients over a lifetime to having heart attacks, stroke, lower extremity events, or other disease entities. And so one can imagine that if that's the biology of atherosclerosis, then there's a set of things we can do to have our patients get better. And the existing and future therapies for every aspect of this is a way to think about how we're taking care of our patients. So first, there's critically important systemic management. Since it's a lifetime disorder with systemic management, we encourage not smoking, trying to eat a healthy Mediterranean diet, trying to stay active, as defined by the American Heart Association as at least 150 minutes of exercise per week, at least 30 minutes or so, 5 times a week. Controlling blood pressure. We have a variety of trials that have shown us that as we lower blood pressure, we have better outcomes for our cardiovascular patients. The lipid part of this, we've thought for a long time around this, and there are statin therapies and non-statin lipid-based therapies. And so we know that it's not just LDL, but that's a key component, and getting the LDL down farther has our patients do better. But additionally, in addition to statins would have been the most proven therapies, there are evolving other therapies there. And then finally, a cardiometabolic disorder with inflammatory and atherosclerosis can't be discussed without thinking about glucose or diabetes. And there's a variety of new agents, as you can see on the slide, that are aimed at that, including SGLT2 inhibitors, GLP-1 receptor agonists, and of course, baseline therapy with metformin, although it's important to recognize metformin hasn't been broadly shown to have as many cardiovascular benefits as some of these newer agents. Now, there's been a lot of interest in anti-inflammatory therapies, and we certainly still hope there are more of those coming. Some have been studied, but currently none are widely used in atherosclerosis. So we talked about the lifestyle prevention and the atherolipid portion. We talked about the anti-inflammatory, and now we're going to talk a little bit about the antithrombotic management. And the antithrombotic management, as an interventional cardiologist, I grew up in a world of the antiplatelet therapy, and certainly those are important. The most common being aspirin, and we've come to learn recently that certainly aspirin is important, but for primary prevention, without having known cardiovascular disease, it may not be as effective as we thought, and the risk benefit's not as clear as we thought. Then there are these agents called P2Y12 inhibitors, clopidogrel, ticlopidine, those types of agents, ticagrelor. Those types of agents are drugs that inhibit platelet aggregation. There are also PAR1 inhibitors and some other agonists coming. And finally, are there anticoagulants at the right dose? Vitamin K antagonists, warfarin has been studied, we're going to talk a little bit about, and then direct acting oral anticoagulants, the newer agents, the factor 10 inhibitors and others. What do we know about those? So when we think about our patient with PAD and CAD, it's important to think about what can I do for their lifestyle? I'll call it behaviors. What can I do for the cardiometabolic prevention? And what can I do for the thrombotic component of their disorder? So it's key to recognize that thrombosis is the critical final common pathway for our patients who then go on to have major adverse cardiovascular events or major adverse limb events. And the way I want you to think about that is that thrombosis is the primary pathophysiologic mechanism that converts this lifetime chronic atheroinflammatory plaque into an acute either limb, heart, or brain-threatening event. And this has probably been going on all the time as these little plaques rupture and heal. But when that fibrous cap gets a little bit more disrupted, the inflammatory reactions start, and we have the entire coagulation cascade. It's important to recognize that that starts with some tissue factor, some actual thrombosis, and you're remembering that biologically, hemostasis is something we want to prevent from bleeding and dying. But when your cells have this thrombotic rupture or plaque is then extruded into your bloodstream, tissue factor and the coagulation cascade starts, and it gets overemphasized both with the platelet and the thrombosis side. That leads to this downstream effect. So the first thing we did when we were studying and trying to understand how to help with this is we started historically thinking about antiplatelet therapies. And those are therapies that inhibit the platelet because we knew about aspirin and we thought about other therapies like that that could prevent that thrombin from getting very stabilized with platelets. And so these therapies, as you can see on the slide, such as aspirin, which inhibits thromboxane A2, help us with some of that platelet aggregation. And then there's a variety of proven therapies that we've used in different places. Those include clopidogrel, prasugrel, ticagrelor. Those are oral agents we give our patients, often with coronary disease who've had a stent, to prevent that stent from thrombosing or preventing more platelet aggregation. There are IV versions of some of these antiplatelet agents, cangrelor being the most common P2Y12 version, but then also glycoprotein 2B3A inhibitors that you can see on the slide that we use in special circumstances. The large data that we have, and we'll show this in a second, have shown us that these antithrombotic therapies focusing on antiplatelet therapy in the circulation have improved our outcomes in our patients. And they were initially preferred over vitamin K and warfarin due to both less bleeding and some less dose adjustment requirements. Perhaps the most important trial early on, now some 20 years ago, was the Capri trial that randomized patients with chronic panvascular disease, so cardiovascular disease, patients with prior atherosclerotic disease, to aspirin versus clopidogrel. And they studied 19,000 patients, followed them over 3 years, and as you can see on this slide, showed a statistically significant but small 8.7% overall risk reduction, or an absolute risk reduction of about 0.5%, meaning you would have to treat 200 patients with clopidogrel instead of aspirin over 3 years to see this reduction in cardiovascular events, which included MI, stroke, and led to clopidogrel being indicated in patients with vascular disease and indicated in patients with PAD. But important also to recognize that it wasn't an extremely large benefit and didn't widely get adopted over aspirin because of the cost. Understandably, if clopidogrel is a little bit better than aspirin, the next question many people asked was, is clopidogrel and aspirin better than aspirin alone? And this trial, also now 15 years or so ago, published by Deepak Bhatt in the New England Journal, called the Charisma trial, studied patients with stable cardiovascular disease or at high risk for ASCVD, mostly diabetic patients with multiple risk factors. They randomized them to clopidogrel or aspirin, or placebo and aspirin. Again, followed them for about 30 months and looked for the first occurrence of MI, stroke, or cardiovascular death. And here again, what you find is it wasn't significantly that different. The absolute risk reduction, again, is about 0.5%. But because of the size of the trial and the duration, it was not statistically significant with a relative risk reduction of around 7% again. It's similar to just monotherapy studies. So adding clopidogrel to aspirin was not significantly better than aspirin alone. And I think an important first message for us in chronic atherosclerotic vascular disease, 2 drugs, dual antiplatelet therapy, DAPT, was not better than aspirin alone. And that's a key message because I think when we got into the stenting world, we did find that DAPT was better. But in the chronic therapy world, we had already shown that it wasn't dramatically better. And this was also on the background of increased bleeding. There was an increase in gusto moderate bleeding in this trial. So as I said, it wasn't better in the chronic therapy, but it was better in the acute coronary syndrome. And this landmark study called the CURE trial, published in early 2001 by Salim Yusuf in the New England Journal, showed us that in patients with acute coronary syndromes, if I treated them with aspirin and clopidogrel, compared to aspirin and placebo, so just aspirin alone, that clopidogrel reduced the incidence of MI, stroke, and death from cardiovascular causes. And this was a pretty broad reduction, as you can see on this slide. Here, the absolute risk reduction gets into the 4, 5% or more. And so you see a significant reduction, and that reduction is even more pronounced in those patients getting a PCI. We've shown that chronic vascular disease does not respond to dual antiplatelet therapy. Acute coronary syndrome seems to be better with dual antiplatelet therapy. What about combining aspirin with warfarin? Did that make a difference? And Sonia Anand colleague of mine, who you'll see in some of these series, published in the New England Journal in the WAVE trial, a randomized trial showing no effect using the combination of aspirin and warfarin on the primary outcome of MI, ischemic stroke, or death from cardiovascular causes in patients who have broad atherosclerotic disease. And the cumulative incidence of these events, including severe ischemia of the peripheral artery and coronary arteries leading to urgent intervention or death from cardiovascular causes, was not significantly different. And of course, warfarin is complicated to use with a bleeding hazard and a variety of dose reduction or increases that have to happen based on using finger sticks. Therefore, it did not become standard therapy. I would say the key therapies takeaways for you at this point is to recognize that the medical management of atherosclerosis is important to think of it as an inflammatory atherothrombotic disorder. And the inflammatory component has yet to be studied well. We don't have a lot of therapies. But behaviorally, with cardiovascular risk reduction with lipids, diabetes, blood pressure, modifying tobacco, increasing activity, that's really critical. Dual antiplatelet therapy has been shown to be more effective at reducing recurrent events in patients with ACS compared to monotherapy. But in chronic therapy, it wasn't dramatically better. And then antiplatelet therapy combined with anticoagulant warfarin was not demonstrated to be better, likely because of dose adjustment, and some of that bleeding hazard. The field is certainly evolving, and we hope you've enjoyed this review of managing our patients with PAD and CAD.